So, as always, here we are with the case again. This is a gentleman who is 45. He has a history of hypertension, and he is brought to the emergency department by EMS with chief complaint of, I feel like I'm having a stroke. EMS gave him a LAM score that was 4. The patient, they called as a stroke alert, and they brought him to your comprehensive stroke center. So neurology is down to evaluate the patient with you. The patient is clearly having a stroke based off of his physical exam. His blood pressure is elevated. He has a blood pressure of 185/100. Neurology says, let's get this patient to the CT scan as quickly as possible. So they whisk him away to the CT scanner. He gets a CT, he gets a CTA of his head and neck. There's no large vessel occlusion that's present on this person's CT scan as well. And you come back, excuse me, neurology is of the mindset, this patient meets the criteria for administration of alteplase. So let's get the patient started. You talk about the risks and benefits of alteplase with the patient, and the patient agrees and consents to having the procedure. The question becomes, what time frame did the patient's symptoms begin? Was it in that 0 to 3 hour time frame, or was it in that little bit longer time frame? And does the literature truly bear out time makes a difference? So we're going to talk about stroke. Time is on your side, or is it? So when we think about patients who come in with stroke, the obvious questions that we want to ask the patient are, the first thing that comes out of their mouth, last known well time. That last known well time really drives what type of intervention we may be able to do for patients. If they're out of the window for TPA, do they meet criteria for maybe a thrombectomy or catheter-directed TPA instead of the systemic TPA that we commonly do give in patients who have met the criteria? That initial evaluation and time of onset is really the only thing that drives whether or not we're going to actually administer alteplase or TPA in this patient population. When we look at the literature, though, is it really that helpful? We start looking at that literature, and TPA becomes forefront on our mind because we oftentimes think that time frame is going to make a difference. So let's delve into this literature a little bit. Let's look back almost all the way at the beginning to find out which literature looks really good for patients getting TPA in a stroke. So we'll start off with a couple of randomized controlled trials looking at things like streptokinase or TPA. And what we find is that at the very beginning, things didn't look that good. It was actually about as good as placebo. So this trial looking at streptokinase versus aspirin, and this is the MAST-1 trial. The MAST-1 trial found no statistically significant benefit to the administration of any type of thrombolytics. Similarly, the Ecast-1 trial, again, found no statistically significant benefits to the administration of TPA in this patient population. So further evidence came out. This was the original NINDS trial, the NINDS trial, which is one of the ones that people kind of hang their hat on in terms of saying that alteplase is actually useful for patients who come in with acute ischemic stroke. Now, there's 2 parts to this study. The first part, NINDS-1, actually found no statistically significant benefit for the use of alteplase in patients with acute ischemic stroke. However, the second part of it actually did show benefit of patients who received alteplase for acute ischemic stroke. They had better outcomes than the patients who received placebo. So there's 1. So certainly if we can get it in this one, we should be able to get it in subsequent studies. Well, here's another trial, the Ecast-2 trial, which again looked at alteplase in acute ischemic stroke. Unfortunately, there were no statistically significant benefits to the administration of alteplase. Here is the MAST-E trial, which looked at streptokinase in acute ischemic stroke, done in Europe, and this one actually had an increased incidence of death due to symptomatic hemorrhage. So not really very good for streptokinase. So maybe we'll just push that one to the side for a little bit. So then we looked at streptokinase again, and what did they find out? Again, increased risk of symptomatic intracranial hemorrhage and death. Similar to desmoteplase. Again, this is the Diaz trial. Again, higher risk for this as opposed to alteplase, higher risk of symptomatic intracranial hemorrhage. But then we looked back at alteplase and said, maybe let's stretch the limits a little bit. Can we look past 3 hours and looked at maybe 4.5 hours as a possible window, increasing that window to administering alteplase. And subsequently, again, they found that there was a statistically significant benefit to the administration of alteplase outside of the 3-hour window, as long as it was less than 4.5 hours from time of onset. Then subsequent studies came out looking specifically at, again, that past that 3-hour window. This is the Atlantis study, and increased incidence of symptomatic intracranial hemorrhage. And subsequent studies, this is a analysis of Atlantis, Ecast, NINS, again, increased incidence of death. Again, looking at desmodoplase, and again, no statistically significant benefit and no statistically significant benefit. So as you've noticed during this so far relook at the literature, you'll notice that there's not very many studies that have looked at alteplase and found really any benefits except for those 2 studies. So based off of those 2 studies alone, despite the world of evidence that has shown worsened outcomes in these patients or no statistically significant benefits, we have based all of our national stroke guidelines on treatment on these 2 studies. But then let's look at those 2 studies. Are those 2 studies actually more relevant than we think they are? So this was the first paper, which looked specifically at the NINS-2 trial. This is done by Hoffman et al. And looked at a reanalysis of the actual data from the NINS trial. So this is the outcomes that came out. This is the results, the discussion that came out from this, the conclusion that came out from this study that said that alteplase performed better than placebo in patients who were having a stroke in terms of modified Rankin score. So here is their data, and I am not a numbers person. This chart could almost look Greek to me. I like to see pictures. I'm much more of a picture person. So this is what a picture reimagining of what that study actually showed. So as you can see here, the patients, this is worse outcomes versus better outcomes. The patients who are in blue are the placebo groups, and the patients who are in green are the patients who received TPA. And it does appear that the patients who had TPA seem to have a little bit of a better outcome compared to the patients who received placebo, whether that was within the 90-minute frame or the 90 to 180-minute frame. But as time went on over that 90 days, you see that difference start to disappear a little bit. And whether or not that means that the patients survive longer, it certainly seems like there's a very small, maybe not so significant improvement in symptoms in patients. But this is the picture that actually kind of I hang my hat on now when I think about TPA and alteplase in patients who come in with stroke. And that is this, which looks specifically at the baseline versus 90-day difference between the placebo and the TPA group, and then the change in the modified or the NIH stroke scale in the patients who receive placebo versus TPA. And as you can see here, there's not really a whole lot of differences between the 2 groups. Between 0 and 90 days, it appears at least that the placebo group as well as the TPA group did universally get better regardless of if they got treatment or not. Similarly, the change in the NIH stroke scale between the people who got placebo and the people who got TPA is not really that statistically significant of a difference. So patients in general, it appears at least, look like they get better regardless of whether they received alteplase or not. When you look completely over the line between 0 and 90 days, the patients who got nothing, no intervention whatsoever, still seem to also get better as long as they survived. Now, obviously, it was dependent on what their modified Rankin score, what their NIH stroke scale was at the beginning, at their baseline, before anything had been intervened upon. If they were higher, obviously they had much more disability, less likely to have return recoverable modified Rankin score. In other words, the modified Rankin scores didn't significantly improve if their NIH stroke scales were higher, but that didn't really change whether they got TPA or placebo. So really, there's not a whole lot of statistically significant difference. When you look at the group that had the lower modified Rankin scores and the lower NIH stroke scale scores, those patients tended to do better regardless of whether they received TPA or not. Remember also, though, that the patients who received alteplase had a statistically significant higher risk of developing symptomatic intracranial hemorrhage. 6% of the patients in this NINDS-2 trial had a symptomatic intracranial hemorrhage. Now, that's not a small number. 6% of the patients, 6 out of 100 patients who received TPA had a symptomatic intracranial hemorrhage, which, from what I remember from medical school, the term was do no harm. So we have to think, does the risk outweigh the benefit? So looking again at this study, does alteplase perform better than placebo? When you relook at this data, there's really not a lot of statistically significant difference between alteplase and placebo. Patients, again, are seen to get better. Now let's look at the Ecast 3 trial. What questions do we have here? Well, when we look back at this trial, again, looking at the difference between 3 and 4.5 hours, is there a role for alteplase in this patient population? Again, their study said that there was. Again, we have to think, though, are we comparing apples and oranges here? So when you look at the data between the patients who received placebo and the patients who received alteplase between 3 and 4.5 hours, you'll find that the TPA group had some baseline differences. The people in the TPA group were found to have fewer baseline strokes. In other words, they didn't have a previous stroke before the initial visit to the emergency department. So they had a history of previous strokes, less likely to happen in the TPA group versus the group who got placebo. Similarly, that TPA group had lower NIH stroke scales compared to the group that had placebo. They had higher NIH stroke scales compared to the TPA group. So those patients who were in the placebo group were probably less likely to have improvement regardless of the fact that they had placebo versus the group that was in the TPA group. Again, these patients do get better when their NIH stroke scale is lower, less history of previous stroke. So did this group get better as a result of nothing, or did they get better as a result of the alteplase that was administered? So when they factored in those baseline differences, what this group found was that alteplase didn't actually have any statistically significant difference between the two. So that factors into a lot of my decision-making now when I come to patients who may have had a stroke. Is there really any data that shows that alteplase is actually useful? What do we do now with this patient population? Well, as Sal alluded to, I think CT perfusion is now our way to go. What do we do with these patients? We should be getting CT perfusion. Now, if you don't have CT perfusion at your shop, which I know that a lot of places don't at this particular time, but I think this is something that's coming down the pipeline. This is something that really is going to help drive our decision and guide our decision-making processes on if alteplase actually has any true statistically significant benefit. I do believe that with true CT perfusion, if there shows that there's a sign that there's really not a big, huge penumbra, but they may have a larger core, in other words, may have something that may be a little bit of a larger stroke, maybe that patient population may have a little bit better outcomes. But in the patients who have had a longer onset of stroke, certainly have a much bigger core, that patient population may not benefit as much from alteplase. So I think CT perfusion is now our way to go in this patient population. So take home pearls from this talk. Number one, more data is needed. Before we just start throwing TPA at everybody who has a stroke, I think we need to, once we've now realized that this data is not as good as we thought it was, we need to see what more data has come. And specifically after the 3-hour range. I think once again, we get to this CT perfusion use a lot more commonly used in the emergency department. That's going to really drive home when we could use alteplase and when it's appropriate. And I think we may see better outcomes in that circumstance. Once again, it's always a pleasure to be here at Rebellion. Thank you again for having me, and I look forward to seeing people's questions at the Q&A.